Good morning, all. Today we'll be discussing infectious diseases of the liver. First, liver abscess. Hepatic abscess is a localized process of encapsulated suppurative material in the liver. More than half of hepatic abscess is found in patients younger than 5 years of age, and 25% of those occur during the first year of life. The commonly encountered entities are pyogenic abscess and amoebic abscess. Tubercular or fungal abscess are rare. The risk factors in pediatric population include chronic granulomatous disease, complement deficiencies, leukemia and other malignancies, sickle cell disease, polycystic liver disease, or congenital hepatic fibrosis, post-transplant liver failure, necrotizing enterocolitis, chemotherapy and steroid therapy, or acquired immunodeficiency syndromes. Bacteria or other organisms enter the liver through various modalities. The biliary tract is the most common pathway through which the bacteria enter. The others are portal vein, hepatic artery, a direct penetrating trauma, or a secondary infection in an unruptured post-traumatic intrahepatic hematoma. Clinical symptoms of liver abscess include constitutional symptoms in 80 to 80% cases, which frequently precede other symptoms and include fever, chills, and malaise. Right upper quadrant pain is seen in 30 to 70%, and it is influenced by the size, especially more than 5 centimeter, location of the abscess, which is closer to the diaphragm, and presence of biliary obstruction. Jaundice is again seen in 8 to 20%. Pleuritic type pain or cough is seen, and specifically more in abscesses involving the segment 7 and 8 of the liver. There is no specific correlation between the symptom and the underlying disease. On examination, fever is present in 60% of the patient and 40% have hepatomegaly. Additional manifestations of jaundice, right upper quadrant tenderness with or without rigidity and guarding and may be present, and decreased breath sounds in right hemithorax may also be seen. For diagnosis, on blood investigation, anemia and leukocytosis are commonly seen in 65 to 70% of the patients. A frequently abnormal liver function test is seen with elevation of ALP, aminotransferases, total bilirubin, and hypobilirubinemia. There is an elevated CRP, but these findings are non-specific and they may be present in many inflammatory and infectious processes. Coming to the diagnosis based on imaging, a patient who presents with fever, cough, and pleuritic pain initially undergoes first and chest X-ray, which shows an elevated right hemidiaphragm with or without pleural effusion. The pathognomic signs of an intrahepatic gas or air fluid levels and portal venous gas are rarely seen. In this X-ray, we can see a subdiaphragmatic collection. The liver abscess is usually a solitary and dominant lesion in 60 to 70% of the patient, most commonly seen in right lobe in 70% cases, and in 15% a bilobar disease is seen. With a sensitivity of 83 to 95%, the first step of evaluation is that with a USG whole abdomen. It is influenced by the size, location, and pathological claim. In the early phase, before necrosis, the abscess is seen as a solid hyperechoic lesion, and it is difficult to distinguish it from the normal liver parenchyma. After liquefaction and necrosis, it forms a complex cystic mass with internal echoes and distal acoustic enhancement, which is seen on this USG. The Doppler that was done did not show any evidence of blood flow inside the lesion. A CCT abdomen for the diagnosis of an hepatic abscess has a sensitivity of 95% and shows well-defined hypoattenuating lesions. Large abscesses, as seen in this image also, is unilocular with smooth margins, or it may be complex with internal septations. Two signs are specifically defined, that are double target sign, which is formed by the inner ring, which is formed because of early enhancement of the abscess membrane. The outer ring is because of delayed enhancement due to edema of liver parenchyma. The cluster sign is seen because of an aggregation of multiple hypoattenuating lesions, which eventually form a large cavity. In this image, we can also see gas in the portal vein, which again suggests the aggregation of the multiple small abscesses. MRI abdomen, though usually less than, show a hypo-intense lesion on T1 weighted imaging and hyper-intense on T2 weighted. Rapid universal wall enhancement is seen with IV gadolinium. The importance of MRI is with MRCP in biliary reconstruction, when we have to see the communication between liver abscess and the biliary tract. In the first image, we can see the enhancing liver abscess, and in the second image, we can see the hepatic abscess in continuation with the right hepatic duct. Usually, though hepatic abscess is solitary, it can also present as multiple abscesses, as in this child was a case of chronic granulomatous disease and had staph infection, and on imaging on USG and CT, with both we can see multiple small abscesses. Hepatic abscess in neonates is also known, and in perinatal period, the cause is direct transplacental bacterial seeding, which is associated with premature rupture of membranes, omphalitis, which may be caused by catheterization of the umbilical vein. Most of the time, these abscesses are miliary and have a disproportionately high representation of gram-negative organisms. They are not thus amenable to percutaneous drainage and require a high-dose long-term antibiotic treatment. If there is a solitary abscess, the organism involved is Staph aureus, and the treatment is usually resection because in neonates it is difficult to distinguish between the abscess and solid tumor. So the abscess, considering that it could be a solid tumor, is resected. Coming to the pathological anatomy, which is seen, the abscess could either be single or multiple cavity, and as seen as yellowish, foul-smelling material because of the necrotic tissue, which may or may not be surrounded by a fibrous capsule. Bacteriology of pyogenic abscesses in our area, mostly it is seen to be Staph aureus. In India, more common is Klebsiella. Most hepatic abscesses, though, are polymicrobial, more so in solitary, more than multiple. Gram-positive foci and gram-negative rods are equally seen. Escherichia E. coli and Klebsiella are more common also, but Enterobacter and Pseudomonas are seen. Blood cultures are positive in about 50% of the patients. Coming to the treatment, the patients usually develop a systemic inflammatory response, and thus aggressive fluid resuscitation is important. The initial management is by a broad spectrum antibiotics, which include third generation cephalosporins and metronidazole, which provides a coverage for gram-positive, gram-negative, and anaerobic organisms. The therapeutic and diagnostic intervention, again, is percutaneous drainage or aspiration under ultrasound or CT guidance. Antibiotic therapy then can be tailored accordingly to cover the specific organisms according to the culture sensitivity of the aspirate. The recommended duration of IV antibiotic therapy earlier used to be 4 to 6 weeks, but recent guidelines suggest that of 2 weeks of IV antibiotic therapy followed by oral antibiotics for an additional 4 to 8 weeks according to sensitivity. The complication rate of pyogenic abscess is 4% with a failure rate of conservative management of 15%. The surgical indications for drainage would be when there is an inadequate response in 7 days, there's a rupture abscess suggested by a clinical deterioration or persistent jaundice, there are multiple macroscopic abscesses, or an abscess is not amenable to drainage, there is associated underlying disease, or the patient is on steroids or has concomitant ascites. Surgically, either laparoscopically, the abscess can be drained, or an open approach can be used via a subcostal incision or an upper midline incision. The abscess intraoperative USG can be used to confirm the location of the abscess, which is aspirated and confirmed and sent for analysis. A hepatotomy is done and a closed suction drain is placed. Liver resection is also an option in rare cases where there is a isolated infected neoplasm or a single or multiple non-healing abscesses are present over a long period. But liver resection in an infected system has a higher complication rate. Coming to amoebic abscess, which is caused by Entamoeba histolytica. The factors associated with increased risk of infection are that exposure to endemic areas, and hence it is also known as tropical abscess, cell-mediated immunosuppression secondary to HIV or steroid use, malignancy, or malnutrition. The pathogenesis of the amoebic abscess starts with the ingestion of food or water contaminated by the Entamoeba histolytica cyst. Once it is in the gut, there is excitation of the cyst that was ingested, mostly in the colon. It is now in 90% cases, the disease is self-limiting and asymptomatic. But in 10% cases, when there are risk factors present, the disease can become invasive. And in less than 1% cases, the disease goes on to become extraintestinal. When there is an inflammation of the cecum via the superior mesenteric vein and the portal vein, it can travel to the liver. And when there is inflammation of the sigmoid via the inferior mesenteric vein and on the portal vein, it can travel to the liver. Mostly right lobe and more specifically the posterior superior surface is involved because of the streamlining effect and the larger size of the right lobe. The trophocytes destroy the hepatocyte by a histiolysin enzyme, which is a cytolytic agent. It causes amoebic hepatitis, forming multiple microabscesses. Once liquefactive necrosis ensues, there is thrombosis of blood vessels and release and breakdown of red cells, forming the classical Encovey-Sauce pus, which is chocolate brown in color and typically odorless. The clinical symptoms of the amoebic abscess, 90% cases of amoebiasis is asymptomatic. Intestinal amoebiasis occurs in 10%, out of which 10% may develop extraintestinal manifestation, of which liver abscess is most common. Acute presentation may be with systemic features, a tender, soft, palpable liver is present with high-grade fever, chills, rigors, loss of appetite, reduced weight, and jaundice. In chronic cases, firm or hard, smooth, non-tender, palpable liver may be present. Abdominal pain and tenderness may be present with localized guarding and rigidity. A mass may be appreciated in right upper abdomen. The liver with soft, tender liver, with or and splenomegaly may or may not be present. Coming to thoracic symptoms, there may be dry cough with chest pain or right shoulder pain, effusion, and a specific intercostal tenderness. Diagnosis, blood investigation show a non-specific anemia, leukocytosis, hypoalbuminemia, increased ALP, and hyperbilirubinemia. Liver ultrasound again depends on the pathological state. Initially has an hyperechoic, ill-defined lesions. Once there is necrosis, it becomes well-defined and hypoechoic. CT scan shows a well-defined avascular hypodense lesion with a hyperdense halo with contrast, as seen on this image also. MRI again is very similar to the pyogenic liver abscess. The most frequent location is right lobe in 80%, of which 80% is present in the right posterior superior region. Multiple abscesses is present in less than 15% of the cases. To perform a specific diagnosis, serum antibodies against Entamoeba histolytica is detected by ELISA. Sensitivity of this test is more than 94% after 7 days of infection, and more than 95% of specificity is associated with this particular test. On percutaneous aspirates, and classical Encoviso's pus is seen, and trophozoites and amoebic antigens can be isolated on analysis. Parasite isolation in stools has been reported in only 24% of the patient. Pathological anatomy shows solid and well circumscribed cavity. On the initially pathological state, it has a yellowish material, but later on shows an anchovy-like Encoviso's pus, which is odorless and pasty with entamoeba trophozoites. The treatment consists of two phases. The initial phase is a 7 to 10 day course of tissue amoebocyte to eliminate the extraintestinal infection. But however, it fails to eliminate intracolonic cyst, which is present in 40 to 60% of the cases. A metronidazole at a dose of 50 mg per kg per day in 3 divided doses is given over a period of 7 to 10 days. Once the diagnosis of amoebic liver abscess is established, intraluminal amoebicide drug is equally important to eliminate the carrier state. Paromomycin or idoquinolone can be given for 20 days or 7 days respectively. There is no specific advantage of routine percutaneous drainage of an uncomplicated amoebic abscess. 90% cases improve after 72 to 96 hours of medical treatment. The indication of percutaneous drainage lies when the patients do not respond to medical management within 4 days, liver abscess is more than 5 centimeters, or it is located in the left lobe of the liver, or there's a high risk of rupture. Percutaneous drainage of the abscess is equally important when the abscess has ruptured into the right pleural space. This again can be followed up on USG. There are complications of the spontaneous rupture of the abscess into the pleura, which is the most common site, which occurs because of erosion of the abscess through the diaphragm. On clinical examination, breath sounds will be reduced and right-sided pleural effusions are more common. An abscess of the right lobe has a relatively lower risk of rupture, but left lobe abscesses in 22% of the cases rupture into the pleura. Percutaneous drainage for the liver abscess usually resolves the condition. However, if that does not resolve, pleural effusion aspiration or ICD may need to be inserted. Rupture into the peritoneum has a 20 to 75% of mortality. In an acute case where it presents with a peritonitis and shock, a higher risk of mortality is present. Fluid resuscitation, anti-amoebic drugs, antibiotics, and surgical exploration is mandated in those cases. Rupture into the pericardium is high mortality. It may also cause a cardiac tamponade. In initial cases, if the function is not compromised, a conservative approach can be tried. But if function is compromised, guided aspiration is important, or a pericardial window may also be needed. There can be erosion into intra-abdominal organs like stomach, but it is a rare entity. Large abscesses may also produce bile duct compression in IBC obstruction or hepatic outflow obstruction and features like Budd-Chiari syndrome. The disease can eventually disseminate to the brain and lungs also. The mortality rate in developed countries where the cases are managed completely is less than 1%. However, recurrent amoebic liver abscesses where Entamoeba histolytica is endemic is common. Surgical indications in amoebic liver abscess include repeated aspirations in spite of repeated aspiration or percutaneous drainage, the abscess cavity fills again. There is thick or multiloculated pus. There is left lobe abscess with a high degree of chance of rupture into the pleura or pericardial cavity. There is a ruptured abscess or the multiple abscess or caudate lobe abscess. The poor prognostic factors on follow-up that need to be monitored are if the abscess had ruptured initially, there was a serum bilirubin of more than 3.5, serum albumin of less than 2, a high abscess volume, and if the patient had significant anemia or is a case of diabetes. On follow-up, LFT needs to be followed and a repeat ultrasound is mandated after 2 weeks to confirm the resolution of the abscess cavity. However, the total resolution of the abscess cavity may take months to a whole year. Summarizing the differences between pyogenic and amoebic liver abscess, there are no specific antibodies in pyogenic liver abscess, but serum antibodies to entamoeba histolytica titer of more than 1:512 is seen. The pus, they aspirate in pyogenic cases are foul-smelling, purulent, and show bacteria on analysis. Amoebic abscess has an anchovy-sauce pus like aspirate, which is odorless and sterile. Jaundice and abnormal chest findings are more common in pyogenic liver abscess and rarer in amoebic liver abscess. An underlying pathology is usually associated with pyogenic liver abscess, and amoebic liver abscess develops mostly in healthy children. Pyogenic liver abscess basically needs a percutaneous catheter drainage with an IV antibiotic course of 2 weeks and an oral course of 4 to 6 weeks. Amoebic abscess can be managed with medical management. If it is non-responsive, then a percutaneous drainage is mandated. Now we'll discuss about the hydatid liver disease.
Morning, everyone. Coming to the topic of hydatid liver disease. So the hydatid liver disease is a zoonosis caused by larval stage of Echinococcus granulosus, also called as Taenia echinococcus. It is the most common cause of liver cysts in the world. There are two types. It is granulosus or multilocularis, of which granulosus is the most common. In humans, 60% of cysts are found in the liver, 20% of cysts are seen in the lung, and in remaining 20% are involves kidney, bone, brain, and muscles. Peak incidence is seen in between 5 to 15 years of age. Both sexes are equally involved, and there are no predisposing conditions for this entity. So the life cycle of hydatid cyst, the definitive host is a dog or some other carnivore. The adult worm stays in the proximal. The adult worm stays in the proximal small intestine of the definitive host, that is dog or other carnivore, and the eggs are passed in the stools in the feces of the definitive host. The sheep, which is the intermediate host, or the humans, which is an accidental intermediate host, ingest the ovum while grazing, or humans after getting in contact with dogs or by eating contaminated water or vegetables get infected with this ovum. The ovum loses its chitinous layer and gets digested in the duodenum. It passes through the intestinal wall, reaches the portal circulation. From portal circulation, it reaches liver, and in liver, it develops into cyst. So in liver, the cyst grows by approximately 1 centimeter in the first 6 months, and by 2 to 3 centimeter annually thereafter. Since liver is the first line of defense, so most commonly involved organ is liver. Some ovas may bypass the liver and get trapped with the lungs, so it forms pulmonary hydatid. So hydatid cyst typically has a 3-layer wall. The outermost wall is a pericyst, which is not the wall for the cyst proper. It is a fibrous tissue layer, which is an adventitious reaction to of the host against the parasite. It acts as a mechanical support. It is a mechanical metabolic interface between the host and the parasite. As the cyst grows, the bile ducts and the blood vessels become incorporated in the cyst wall, which are responsible for the biliary and hemorrhagic complications during operative procedure. And over time, the pericyst calcifies. Second layer is the ectocyst or the laminated membrane. This is the outer layer of the cyst itself, that is cyst proper. It is formed by the endocyst, that is the germinal layer. It is a bluish white gelatinous 0.5 centimeter thick layer. It is a cuticulous structure without nuclei. It acts as a barrier for bacteria and is an ultrafilter for protein molecules. So the most important layer is the endocyst or the germinal layer. It forms hydatid cyst, hydatid fluid, ectocyst, brood capsules, scoliosis, and daughter cyst. It is 10 to 25 micrometer thick, and it is attached tenuously to the laminated membrane. The absorptive function is responsible for the cyst nutrition, and its proliferative function is responsible for producing ectocyst and the scoliosis. It forms small cellular masses, that is brood capsules, in which the future worm head develops. It develops into invaginated proctoscolix with 4 suckers and double row of hooks, that is a proctoscolix. This fully differentiates and matures attached by pedicle to the capsule wall. So the proctoscolex has can develop into two forms. It develops into an adult tape form in the definitive host, and it develops into a new hydrated cyst in the intermediate host. So the what is hydrated sand? The released free proctoscolex, root capsules, and the calcareous bodies are constitute the hydrated sand. And in hydrated sand, we have 4 lakh scoleces per ml. So the development of root capsules from germinal layer represents complete biological development of the cyst, which takes about 6 months of growth. So there are two terminologies, that is endogenic vesiculation and ectogenic vesiculation. Endogenic vesiculation is a term used for formation of daughter cyst. Since hydrated cyst in humans is long-standing, large, and liable to injury, any injury will lead to daughter cyst formation. The daughter cysts are replicas of mother cyst. The size and numbers are variable. The content of uncomplicated cysts are sterile, colorless, and it is an antigenic fluid containing salt, enzymes, proteins, and toxins. The other entity is an ectogenic vesiculation. This is seen in the larval stages of Echinococcus multilocularis. It is a fulminant disease in which through a small rupture or defect in the laminated membrane, the germinal layer passes outwards and forms a satellite hydrated cyst. The liver parenchyma in humans cannot sequester Echinococcus multilocularis, so the process becomes very fulminant. Multiple vesicles are formed in all directions. The parenchyma has a multilocular appearance. The center becomes spongy, necrotic, and filled with gelatinous fluid similar to mucoid liver carcinoma. In worst cases, it can lead to hepatic insufficiency. So the clinical presentation of hydrated cyst depends upon the site, size, stage of development, and whether the cyst is alive, dead, or infected. Most cases are asymptomatic, and in 25% of the cases, patients may present with pain in the right hypochondrium or epigastrium for a prolonged period of time, along with right to right type chest pain if there is concomitant rupture of the through the diaphragm into the pleural space. Patients may present with hepatomegaly or palpable mass in 50% of the patients. Patients may present with jaundice or anaphylaxis due to rupture into the biliary tree, and there can be some non-specific signs such as fever, fatigue, nausea, or dyspepsia. Most of the lesions are solitary, that is 80% cases, and predominantly in the right lobe in again 80% of the patients. Even though the lesion is single, half of them contain daughter cyst and are multilocular. The diagnosis depends upon the high index of clinical suspicion. Most of the patients are asymptomatic, presents with chronic symptoms of dyspepsia, non-specific fever, jaundice, and the symptoms could be due to either toxic reaction from the presence of parasite or because of local mechanical effects. So for diagnosing, we have some serological test, but no serological test is completely established for diagnosing it. The earlier done Cassoni's and Weinberg tests have no sensitivity, so are no longer done. The indirect heme agglutination test is a more specific test which lacks sensitivity. The titers of 1:512 is positive for tissue invasion, 1:128 is suspicious, and 1:32 is negative for tissue invasion. ELISA test is positive in case of 96% of patients, and complement fixation test is positive in 89% of patients. In imaging, in plain X-ray, we can see an elevated diaphragm or a concentric calcification in this. So 96% patients.
Sensitivity and specificity.
Sensitivity is the.
But still, ELISA is probably the best test for both the MIS and yes. It's very confirmed because between complement fixation and rehabilitation test was recommended for this. Nowadays, we are getting these ELISA.
So the diagnostic imaging modality is either USG or a CT scan. USG is specific in 90% of cases. We can see the internal structure, the number, and the location of the cyst. We can also look for the complications. In childhood hepatic echinococcus disease, imaging of the lung is very important because pulmonary hydrated is more common in pediatric age group rather than liver hydrated disease. The USG-based cystic classifications are Garvey classification and the informal group of echinococcus given by WHO. So the classification is type 1 is a unilocular or anechoic cystic lesion with a double line sign, as seen in the first image, which is double line sign. Then is the floating membranes, which is also called as water lily sign. Then we have the honeycomb-like cyst or a rosette appearance, which is called as it is a type 3. This is called as CE2 as per WHO classification, and another CE3B is in which there are cysts with daughter cyst in a solid matrix. Type 4 is cyst with solid matrix, cyst with a heterogeneous equitextured complex, and type 5 is a solid cyst with calcified wall. So in CT, we can look for the daughter cyst. We can helps to look for the exogenous cyst, and cyst volume can be estimated. CT is imperative for operative management. That is why laparoscopic approach. MRCP may show communication with the biliary system. ERCP and PTC will also serve the same purpose. However, it can be also used to drain the biliary tree before surgery. So then in the first diagram, we can see liver hydatid which has ruptured through the diaphragm into the pleural space. In the scan below, we can see heavily calcified cystic lesion on the right lobe, and another partly calcified cystic lesion in the left lobe of liver. In the left upper side, we can see another cystic lesion in the same patient in the gallbladder fossa. And in ERCP, we can see the communication of the hydatid cyst with the biliary tree. The treatment consists of either drug therapy or surgical intervention. So if in drug therapy, we give either benzimidazoles, that is albendazole or mebendazole. Albendazole is given at a dose of 10 to 15 milligram per kg per day, given along with fatty meals to increase the absorption. It is usually given 3 months preoperatively because it reduces the recurrence rate because of cyst spillage, partial cyst removal, or biliary rupture. Mebendazole can be used as an alternative. However, it is less effective than albendazole. Dosage recommended for mebendazole is 40 to 50 milligram per kg per day. The adverse effects of using benzimidazoles is it results in elevated liver transaminases. It leads to leukopenia or thrombocytopenia or a reversible hair loss in 2% of the cases. Praziquantel is a drug which is not effective as monotherapy. However, it boosts the intercystic albendazole levels. The WHO recommends a dosage of 40 mg per kg once a week as an adjunctive therapy. Coming to the surgery. The indications for surgery are removal of large CE2 and CE3B lesions. CE2 and CE3B lesions are those lesions in which there are multiple daughter cysts forming honeycomb, in which puncture of the individual cyst would not be easy, and drug might not help in eliminating all the cysts. So such cysts of CE2 and CE3B are considered for surgery, in which multiple daughter vesicles are not suitable for percutaneous treatment. A single liver cyst which is situated superficially and having risk for spontaneous or rupture because of trauma are again considered for surgery. Infected cyst, impending rupture, cyst communicating with the biliary tree, and cyst exerting pressure on the adjacent vital organs, and cyst with hemorrhage are considered for surgical therapy. The principles of surgery are to inactivate the parasite, to remove as much parasitic material as possible, to minimize the leakage and spillage of cyst contents, to manage the residual cavity, and to manage the complications. We should always remember that proctoscolex or the germinal membrane, if at all left behind at operation, will lead to formation of new daughter cyst. The terminologies used for surgery are as given by Pavlovsky is either hepatic resection can be done in patients with multiple cysts which are in close proximity to a major blood vessels or to each other, and in cysts which are in a relatively safe location, that is segment 2 and 3 isolated. Pericystectomy, it involves the removal of the whole cyst envelope, including the adventitia, without resection of the healthy liver tissue, and cystectomy, which involves removal of the endocyst along with the cyst contents. Other procedures recommended are an open cyst evacuation. These are best for peripherally located cyst using an abdominal or flank approach. The recurrence rate is 10 to 30%. Laparoscopic cyst evacuation can be done for a peripherally located cysts which are situated anteriorly and should not have a thick calcified wall. The exclusion criteria for laparoscopic cyst evacuation is deep intraparenchymal cyst, posteriorly located cyst, more than 3 cysts, and cyst with a thick or a calcified walls. The techniques recommended for obliterating the cavity of the cyst is capitonage, in which multiple imbricating sutures are taken to close the cavity. We can place in the omentum, and which is called as omentoplasty, and we can marsupialize the cyst wall, and external tube drainage can be done. So this is a diagrammatic representation of an open cyst evacuation, which shows cyst aspiration. Another picture of a picture showing demonstrating removal of daughter cyst. Then there's a diagram representing resection of an active cyst lining. Then this is omentoplasty, in which the cyst contents have been aspirated and washed, and packing has been done with omentum. Then then comes the pericystectomy, in which involves removal of calcified pericyst. In the upper figure, we can see the after removing the cyst contents and removal of the germinal layer. If we see a bile oozing from we can close the small bile duct. And in last figure, we can see there's closure of the cavity over a drain. There's an intraoperative picture showing marsupialization in which the cyst wall has been sutured. And in second picture, we can see cyst deroofing in which the cyst wall has been ruptured, deroofed, and cyst contents have been aspirated. So the morbidity and mortality in hydatid cyst varies. Mortality ranges from 0 to 7%, depends upon the type of operation and the intra-abdominal complications. The predictors of morbidity are the cysts which are located in the dome, cysts, those with cystobiliary fistula, and those cases in which there is intrabiliary rupture of a cyst. Deaths are reported in case of anaphylaxis or septic shock in patients with external biliary fistula, in patients with infection of the residual cavity or a residual hydatid membrane in CVD or post-operative hemorrhage. Then there is a condition. Then there is a technique of pair. This is a technique in which a percutaneous approach is used, where we puncture the cyst, we aspirate the contents of the cyst, we inject these polycetal agents, and after which the catheter is kept clamped for around 30 minutes, and then we re-aspirate the entire contents. This pair technique is not recommended for a honeycomb type of cyst in which we cannot puncture each and every cyst. The relapse rate are 48 to 59%, and the recurrence rate is 0 to 4%. Major complications are rare. However, minor complications range from 10 to 30%. The scolicidal agents used are hypertonic saline in 20-30% hypertonic saline. WHO recommends using 20% normal saline, hypertonic saline, 3% hydrogen peroxide, 10% povidone iodine, and 95% ethanol can be used. Other agents are chlorhexidine gluconate, cetrimide, or polyvinyl permanganate iodine. Thus, what helps the scolicidal agent are helpful for? They helps in they kill the proctoscolex inadvertently left in the cyst cavity or spilled at operation. They kill any remnants of germinal membrane. The scolicidal agent should not be injected into cysts which are communicating with the biliary tree because they can lead to chemical sclerosing cholangitis. The scolicidal agent should be left for around 6 minutes. That is the recommended time. However, WHO says that because of dilution, it should be kept for at least 15 minutes. And the complication is because of we are using hypertonic saline, it can lead to hypernatremia. So the indications for pair are any cyst with a drainable material, that is type 1, type 2 cyst definitely, and type 3, type 4 cyst with drainable material, infected hydatid cyst, inoperable patients, pregnant women, and in patients with multiple disseminated or symptomatic cysts. Contraindications are it is not done in children below 3 years of age, cysts which are inaccessible to puncture, and in liver cysts that are ruptured into the biliary system or peritoneum in which open evacuation is considered, and in subgroups of type 3 and type 4 with a solid content, the pair cannot be used. There's another technique, that is modified pair technique, in which involves concomitant evacuation of the cyst contents with simultaneous infusion of scolicidal agents via specially designed coaxial catheter system. The advantages is that it allows complete washout of cyst content, reduces chances of any scoliosis surviving, and it maintains the intracystic pressure, so it reduces the risk of biliary fistula formation. The complications of hydatid cyst disease are the cyst can rupture internally or externally into the peritoneal, pleural, or pericardial cavity. It can there can be secondary infection, anaphylactic shock can happen, or patients can land up in severe hepatic insufficiency. There can be compressive atrophy of the surrounding hepatocytes or fibrosis. The cyst can enlarge to replace the entire lobe, which has a risk for spontaneous rupture. The cyst can have communication with the biliary sea, leading to biliary leakage or fistula postoperatively, or patients can present with abscess or a biliary peritonitis. The cyst can also rupture through the diaphragm and presents with symptoms of pulmonary symptoms due to pleural effusion. These are the indications for percutaneous or laparoscopic evacuation and open evacuation in uncomplicated and complicated patients. In all complicated patients who have communication with the biliary tree, pulmonary communication, or peritoneal rupture, the only indicated treatment is open evacuation. As such, the laparoscopic approach is advised for Garvey type 1 and 2, cyst located anteriorly, cyst located in peripherally located cyst, only 1 to 3 in number, small cyst, and cyst without calcification. For Garvey type 4 and 5, those lesions who have posterior cyst, centrally located cyst, cyst more than 3 in number, a large cyst, and those which are heavily calcified are considered for open evacuation. Follow-up in cystic echinococosis is done by a USG at 3 months post-procedure, and then it is followed 3 to 6 monthly. MR is done in follow-up when cysts are less easy to visualize by ultrasound and detailed visualization of biliary tree is required. Serology alone is inappropriate, although the post-treatment CE-specific IgG2 antibody response is a useful correlate of disease activity. Follow-up should be at least for 10 years. Coming to the alveolar echinococcosis caused by multilocularis, the humans get infected by ingesting eggs passed in fox or dog feces. The cyst is sponge-like in appearance and is made up of irregular vesicles from size less than 1 to 20 mm in size. The liver stages are not surrounded by fibrous capsule. However, there is strong fibrous response by the human host. So, Echinococcus multilocularis vesicles are found within fibrous stroma. There is central necrosis, which mimics an abscess cavity, which it may also get complicated by a secondary bacterial infection. In contrast to Echinococcus granulosus, metacystodes of multilocularis rarely form root capsules and proctoscolis in humans. So this is the life cycle. This is the life cycle. How the humans transmission stage. How the humans get infected. The eggs are passed in the fox species, and the eggs are ingested by humans by drinking contaminated water or vegetables, and zoocyst develops in liver of the humans. The clinical presentation of multilocularis, it is mostly asymptomatic for 5 to 15 years. It runs a chronic course. Patients can present with abdominal pain, jaundice, anemia, or fever. Late-stage disease has severe liver dysfunction, often with portal hypertension. It resembles a slow-growing cancer, diagnosed unexpectedly following biopsy of a suspected tumor. Adjacent organs can be involved by a diet spread or a distant metastasis. Alveolar echinococcosis caused by multilocularis follows accelerated course with HIV co-infection. So in such cases, highly active antiretroviral therapy along with antiparasitic drugs are given. In imaging, the alveolar echinococcosis is not characteristically cystic. USG shows mixed hyperechoic and hypoechoic areas. CT and MRI can give further characterization and helps in staging of the lesion. In contrast to cystic echinococcosis, alveolar echinococcosis is FDG PET positive. So to diagnose, there are specific EM2 ELISA test. Histopathology shows vesicles within a fibrous stroma. The parasitic membrane is pass chain positive. And PCR can be done on tissue biopsies using a pan-cystode 12S RRA target. The staging is PNM staging, where P stands for hepatic localization of the primary lesion. PX stands when primary lesion cannot be assessed. P0 is when there are no detectable liver lesions. P1 is a peripheral lesion without proximal biliary or vascular involvement. P2 is a central lesion with proximal vascular or biliary involvement of one lobe. P3 is again a central lesion with a hilar vascular biliary involvement of both lobes or with involvement of two hepatic veins. P4 is any lesion with extension along the portal vein and inferior vena cava or hepatic arteries and biliary tree. N represents extrahepatic involvement of neighboring organs and tissues. NX is when this extrahepatic involvement cannot be evaluated. N0 when there is no involvement, and N1 when there is involvement of the neighboring organs and tissues. And M stands when there is absence or presence of distant metastasis. When it cannot be validated, it is MX. When there are no metastasis, it is M0. And when metastasis is present, it is M1. So the treatment is mostly surgery wherever possible with adjunctive antiparasitic drug therapy. Hepatic resection is the operation, is a surgery of choice in which we excise the whole lesion with a 2 centimeter margin. The resection can be an R0 resection in which there are no residue. It can be an R1 with a microscopic residue or an R2 resection with a macroscopic residue. The Kern et al. Advise routine removal of regional lymph nodes. For intralesional abscesses and jaundice, palliative percutaneous drainage can be done. Bile duct strictures can be managed by endoscopic dilatation and stenting. When liver resection is not possible, such patients are considered for liver transplantation. WHO recommends that when there is severe liver insufficiency and inability to perform liver resection, and when there is absence of any extrahepatic lesion, we can consider patients for liver transplantation. Follow-up is done for at least 10 years. After radical resection, albendazole is given for 2 years. However, if the lesion is inoperable or an incompletely resected lesion, albendazole should be given indefinitely. In inoperable cases, the follow-up should be lifelong. Coming to the last few slides about the cystic pulmonary hydatidosis, very important in case of pediatric patients. The embryos can reach the lung. The size of the embryos, which are less than 0.3 mm in size, bypass the liver and they go via hepatic veins into the right heart, and from there it goes to the pulmonary circulation and forms cysts in the lungs. It can reach via thoracic duct through lymphatics of the small intestine. through lymphatics of the dome of the liver and diaphragm, through venoveral anastomosis in the liver and the space of Retzius. There can also be direct pulmonary exposure through inhalation of air contaminated with Echinococcus eggs. There can be secondary hydatidosis to the rupture of the primary cyst. There can be metastatic lung lesions to the rupture of cyst into right heart chamber, IVC, or rupture into of a bony cyst. The clinical presentation of pulmonary hydatiditis is uncomplicated, small when peripherally located cysts are mostly asymptomatic, discovered incidentally on chest radiography. Cysts which are larger than 5 centimeters can cause bronchial compression. Cyst might rupture and patients may present with sudden onset of chest pain, cough, fever, and hemoptysis. A condition called as hydatidosis, where there is perforation of cyst into the bronchiole and patients start having expectoration of germinal membrane and hooklets of the parasite. So in the first CT image, we can see CT image of the thorax, in which we can see a cystic lesion with the floating membranes. That is a water lily sign. Then we have a ruptured hydatid cyst in the lung with an air bubble sign. This is an air bubble sign. And we can see multiple hydatidosis in the third picture. The management is either pharmacotherapy or surgery. Drugs are given for at least 3 to 6 months. In case of the indications are smaller cyst, those with poor surgical risk, multi-organ disease, multiple cyst or recurrent cyst, and any case with intraoperative spillage of hydatid fluid. Contraindications are for large cyst at risk of rupture, any inactive or calcified cyst, those with bone marrow depression, and in first trimester of pregnancy. Or in surgical therapy, the indications are large cysts which are superficially located and likely to rupture, infected cysts, cysts in vital anatomic locations, and cysts exerting substantial mass effect. The techniques recommended are either enucleation, pericystectomy, cystostomy with capitonage, and open aspiration or lung resection. So to summarize, conclude, how to prevent the transmission of the disease by a public education about life cycle and transmission of the disease, washing hands after contact with canines, eliminate consumption of vegetables grown at ground level, and we should stop feeding entrails of slaughtered animals to dogs.
Covered, but I think there's hydatid cyst itself. I think it might not be that common, but